We'll continue with our discussion for DSM-5 TR. Today, we would actually take up substance use disorders. In summary, the substance use disorder are about the use disorder of about 10 classes of substances or drugs. Welcome, everyone. We'll continue with our discussion for DSM-5 TR, Diagnostic Criteria for Substance Use Disorder or Substance Use Disorders. The substance disorders or substance-related disorders are actually two: substance use disorders and substance-induced disorders. Today, we would actually take up one part of that, and that is substance use disorders. In summary, the substance use disorder are about the use disorder that we'll discuss of about 10 classes of substances or drugs. These include caffeine as well. However, in disorders, as you would see the classification and severity criteria, caffeine is actually not included as a disorder-causing substance. Although it is included in the list, but the criteria does not include that. So let's start. Let's start from here. Some references quickly. This is CDC. This is American Psychiatric Association's page. This is also something about the history. Then the International Classification of Diseases, ICD-11, not 10. And there is a part of our discussion that is connected to ICD-11. So I have that over here as a reference. Then this is a good table, quick reference as well. And finally, one more, DSM-5 TR assessments and measures. So let's go to my presentation. I have no disclaimers, no declarations, no conflict of interest. Objective is, number one, an introduction to Diagnostic and Statistical Manual of Mental Disorders, version 5 Text Revision. So this is DSM-5 TR, and it is copyrighted. This book is copyrighted to American Psychiatric Association. I'm going to show you some parts of it. Then substances in this context. So what do we mean by substances that we're talking about today? And then diagnostic criteria, then specifiers, and then severity. So let's look at a brief history, just briefly, the history of the Diagnostic and Statistical Manual. So this work of DSM was even here in 1921, pre-World War I, then post-World War I, then DSM-3 was created, and this work began on DSM-3 in 1974, and it was published in 1980. Then if you see DSM-3R and DSM-4, this was developers of DSM-4 and the 10th edition of ICD. So DSM-4 was synchronized with ICD, work closely to coordinate their efforts, resulting in increased congruence between the two systems and fewer meaningless differences in wording. ICD-10 was published in 1992. DSM-4, if you see here, was published in 1994. Still, they were quite congruent to each other. That is lesser the case for DSM-5 TR and ICD-11. Then was DSM-5. DSM-5 was published in 2013. Keep in mind, we are in 2024 now. DSM-5 TR was published in March 2022. The work on this version that we are looking at today, DSM-5 TR, it began in spring of 2019 and then published in 2022, almost 10 years in the working from DSM-5 to DSM-5 TR. Okay, so with this brief history, how does CDC look at substance use? It's not the disorder, the use. So CDC says substance use refers to the use of selected substances, including alcohol, tobacco products, drug inhalants, and other substances that can be consumed, inhaled, injected, or otherwise absorbed into the body with possible dependence and other detrimental effects. So I think an important part here is the dependence. There can be many substances that we use on daily basis, consume on daily basis, and they may not be causing dependence. But here, possible dependence and detrimental effects. That is the important keywords here. Now, the DSM-5 TR, this manual, talks about the substances that can have their use can cause disorders. And remember that they're not using the term addiction anymore, and we'll touch on that later. We're talking disorders. The substance classes that can result in disorders, their use, are alcohol, caffeine, cannabis, hallucinogens with separate categories for phencyclidine or similarly acting aryl cyclohexylamines and other hallucinogens, inhalants, opioids, sedatives, hypnotics or anxiolytics, stimulants, tobacco, and other substances. So now, first, to go to the substance use disorder, we have to understand what is mental disorders, because substance use disorders are actually categorized within the mental disorders. Then we'll see what are substance use disorders. Then we'll see individual disorders, which will be in the future lectures, for example, alcohol use disorder or opioid use disorder. So the definition of mental disorders, this is DSM-5 TR. A mental disorder is a syndrome characterized by clinically significant disturbance, cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental process underlying mental functioning. So that is a mental disorder. Remember that this DSM-5 is actually diagnostic and statistical manual for the mental disorders. So a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in psychological, biological, or developmental processes underlying mental functioning. So that is the mental disorders. And if you see this book, there are a lot of disorders, anxiety disorders, sleep disorders, and so on. Substance use disorders are just one category. Now, what is then substance use disorders? According to the American Psychiatric Association, substance use disorder is a complex condition in which there is uncontrolled use of a substance despite harmful consequences. And we have done this discussion in the past as well, that how do those harmful consequences start coming together? What are neurological changes that can happen in the person's physiology, which would then make them dependent, even to the point that there is harm? People with substance use disorder have an intense focus on using a certain substance, such as alcohol, tobacco, or illicit drugs, to the point where the person's ability to function in day-to-day life becomes impaired. And we did this discussion as well in a complete lecture about the disorders and what is the mechanism behind the seeking and persistently seeking substance. People keep using the substances even when they know it is causing or will cause problems. The most severe SUDs are sometimes called addictions. So again, in this particular manual, they tried to move away from the term addiction and went to the term as alcohol use disorder or opium use disorder. So they went to more neutral terms. Now, DSM-5 TR on absence of term drug addiction. And drug addiction is a term that is very commonly used, and it is still found in literature. But with the DSM-5 TR, they try to move away from this term. So here is what they say. They say that note that the phrase drug addiction is not applied as a diagnostic term. So to say someone that, hey, you have drug addiction, according to DSM-5 TR, that is not a diagnostic term anymore. Is not applied as a diagnostic term in this classification, although it is in common usage in many countries to describe severe problems related to compulsive and habitual use of substances. So it is present even in the books, pharmacology books or substance-related books. You would see the term addiction even as recent books as last year's or a couple of years ago. But from the DSM-5 TR's point of view, that term is now kind of not used. The more neutral term, substance use disorder, is used to describe the wide range of disorders from a mild form to severe state of chronically relapsing compulsive patterns of drug taking. Chronically relapsing compulsive patterns of drug taking. Some clinicians will choose to use the phrase drug addiction to describe more severe presentation, but that wording is omitted from the official DSM-5 substance use disorder diagnostic terminology because of its uncertain definition and its potentially negative connotations. So if we say that somebody is drug addicted, then they say that this definition is not very certain, not very, it doesn't illuminate the problem, and it has a negative connotation or potentially negative connotation. So they're moving away from this. Now, restructuring of substance use disorder for consistency and clarity. So in this DSM-5 TR, they did a lot of work. There were 200 researchers that were working on this DSM-5 TR for 10 years. And then there were 5 main groups of organizations as well that were also looking into this. Then there were other groups that were allowed to look at the DSM-5 TR manuscript and make changes or suggest changes to it. So it was a work that was done over 10 years. So the categories of substance abuse and substance dependence have been eliminated. Remember, we talked about dependence and we did a complete lecture about what is dependence, and that was somebody that has a legitimate need for a specific substance, for example, let's say opioids for pain, and they are not, from the use, they may have withdrawal, but they are dependent, they're not addicted. So here they're saying the categories of substance abuse and substance dependence have been eliminated and replaced with an overarching new category of substance use disorders with the specific substance used defining the specific disorder. So, for example, this would be opioid use disorder instead of opioid addiction, or alcohol use disorder instead of alcohol addiction. Dependence has been easily confused with the term addiction, when in fact the tolerance and withdrawal that previously defined dependence are actually very normal responses to prescribed medication that affects the central nervous system and do not necessarily indicate the presence of an addiction. This is a very important statement. The dependence, the use of this term has been confused with addiction. So if we said this patient is dependent, it is easy to confuse them to say, well, they're addicted. Here they are saying when in fact the tolerance and withdrawal. So tolerance, we did a complete lecture about what is tolerance, and the tolerance would be when a person needs more and more dose, escalating dose for the similar effect, or the same amount of same dose does not produce the same intensity of effect as it was doing before. And we actually did this discussion that there is tolerance that is immediate and then within weeks and then within months, remember? And we talked about the neurological mechanisms behind that as well. So here they're talking about that, and they're saying, in fact, the tolerance and withdrawal that previously defined dependence are actually very normal responses to prescribed medication that affect the central nervous system and do not necessarily indicate the presence of an addiction. By revising and clarifying these criteria in DSM-5, we hope to alleviate some of the widespread misunderstanding about these issues. So then they talk about the DSM-5 TR classification. Before each disorder name, ICD-10 CM codes are provided. So if you look at this, let me actually bring it up. This is the manual. And if you see here in this manual, if I just show you a little of their work. So here, if you see ADHD and disruptive behavior disorders, or anxiety, obsessive compulsive spectrum, etc., then childhood and adolescent disorders, and so on. So with each disorder, eating disorder, mood disorder, with each disorder, they have the ICD-10 codes there. That's what they're talking about. So before each disorder name, ICD-10 CM codes are provided. Blank lines indicate that the ICD-10 CM code depend on the applicable subtype, specifier, or class of substance. So anyways, the point is that they have those codes as well. And they talk about ICD-11, that they were not able to, this is their harmonization with ICD-11 paragraph. And they go in a detail for why ICD-11 is not fully harmonized with the DSM-5 TR. DSM-5 TR work was a little ahead of ICD-11, but they did have an attempt afterwards to try to make them congruent. So the group task, the harmonization with the ICD-11, there was an attempt to do that. So the group tasked with revising the DSM and ICD system shared the overarching goal of harmonizing the two classifications as much as possible for the following reasons. So now there are two. One is the DSM-5 TR codes, and then there is the ICD-11 codes. And of course, you can actually imagine that why they should be congruent and harmonized. So what they're saying is the existence of two major classifications of mental disorders, hinders the collection and use of national health statistics. The design of clinical trials aimed at developing new treatments and the consideration of global applicability of the results by international regulatory agencies. So the data is in the clinical trials, the data is present in various global entities as well. So how do you harmonize all of that data so that the stats can be correctly understood and the disorders can be uniformly understood? So that was one of the reasons that they wanted to harmonize these. More broadly, the existence of two classifications complicates attempts to replicate scientific results across national boundaries. And even when the intention was to identify identical patient populations, DSM-4 and ICD-10 diagnosis did not always agree. So even DSM-4 and ICD were not very congruent, and now DSM-5 TR and ICD-11, so they wanted to make them congruent as well. So just to give you an idea that there is a slight miscongruency there. So now to the actual discussion of the diagnostic criteria. So the DSM-5 TR, the way the diagnostic criteria is put together, there are 11 criteria which should be assessed to diagnose a patient for substance use disorder. So the very first table in this list or in this discussion of the substance use disorder, they have the diagnosis associated with substance classes. So if you see here, for example, on the top, it says psychotic disorders, bipolar and related disorders. Imagine any substance, opioid, alcohol, hallucinogens, inhalants, imagine them and then think about these are the main categories in which these disorders can appear. Bipolar, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, sleep disorders. To give you an example, so of course I have them all over here. In this table, the I and W, I means the specifier with onset during intoxication. So for example, let's look at alcohol. Alcohol, psychotic disorders caused by alcohol are I and W. That means psychotic disorders can be present when the intoxication is occurring, or W means they can be with the withdrawal. So when you are looking at some of these disorders in a patient who has substance use disorder, you can use I or W or both, depending upon how the disorder is started or when the disorder is observed. So when you put I there, that is with onset during intoxication. When you put W there, that is the specifier with onset during withdrawal. And if it is IW, then that is either with onset during intoxication or with onset during withdrawal. So if I see here alcohol, psychotic disorder, IW, that means alcohol intoxication can cause psychotic disorders, or with withdrawal of alcohol, the psychotic disorders can occur. So this is one table. For example, if we look at opioids, that is what we have been discussing. So if you look at opioid row, depressive disorder with intoxication or with withdrawal, and anxiety disorders with withdrawal, not with intoxication. Similarly, sleep disorders from opioid with intoxication and with withdrawal. Now, substance use disorder diagnosis. Overall, the way to diagnose this is that there are some broader categories and you diagnose patient in each category. And these are, number one, impaired control. And how do you diagnose that the patient has impaired control? Or what are the factors that are within this impaired control? That is what we'll see next. Impaired control, social impairment, risky use of that substance, and pharmacological criteria. These are the four broader categories in which the diagnostic criteria are present, and then you use them to understand if there is a diagnosis of substance use disorder. Then you can actually provide, based on the number of symptoms present, you can then provide the severity as well. So let's look at these. So first of all, substance use disorder, impaired control. Remember that there are impaired control, social impairment, risky use, pharmacological criteria, impaired control. This is the criteria number 1 to 4. There are total 11. Impaired control, first criteria. The individual may take the substance in larger amounts or over a longer period than was originally intended. Impaired control. So taking it in larger amounts than intended, originally intended, or for longer period of time. That is criteria 1. So for example, if there's a patient or if there's a person who is using opioids and then they are increasing the use of opioid, the dosage, or they are using opioids beyond the intended time, then the criteria number 1 will be satisfied. Criterion 2. The individual may express a persistent desire to cut down or regulate substance use and may report multiple unsuccessful efforts to decrease or discontinue use. So, for example, saying that I want to discontinue alcohol, I have a desire, I've tried to stop it, I want to stop it, or smoking. So, the individual may express a persistent desire to cut down or regulate substance use and may report multiple unsuccessful efforts to decrease or discontinue use, then the criterion 2 is satisfied. Impaired control, I just want to remind you, this is within that. Criterion 3, the individual may spend a great deal of time obtaining the substance, using the substance, or recovering from its effects. That is criterion 3. Criterion 4, craving. Craving is manifested by an intense desire or usage or urge for the drug that may occur at any time, but is more likely when in an environment where the drug previously was obtained or used. That is craving. So this desire can occur any time, but more commonly in that environment where it was previously used, obtained or used. Now, craving, this is a very important criterion, number 4. Craving might be queried by asking if there have ever been a time when there were such strong urges to take the drug that the individual could not think of anything else. So you can ask a patient that has there been a time that you wanted the drug so much that you could not just think of anything else? And there's another very important thing here, and that is this current craving. How is your craving now? Current craving is often used as a treatment outcome measure because it may be a signal of impending relapse. So not only it is a criterion for diagnosis, this can be used to assess if there may be an impending and imminent relapse about to occur. So these are the 4 impaired control criterion. Then is the social impairment. And they're not mutually exclusive to each other. And they kind of are overlapping with each other as well. So social impairment, this is criteria 5 to 7. So 3 criteria here, 4 criteria in the impaired control, 3 criteria in this one, 7, and then you would see 2 here and 2 here. So now social impairment, criterion 5, recurrent substance use may result in a failure to fulfill major role obligation at work, school, or home, right? Makes sense? Recurrent use of it is impairing the person from the role, major role, in the obligation at work, school, or home. That is criterion 5 satisfied. Criterion 6, the individual may continue substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effect of the substance. So interpersonal problems or social problems because of the effects of the substance, but the patient still continues. So the individual may continue substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. I remember in one of our talks about opioid in the previous lectures, we discussed this in detail, that how this aggressive seeking behavior develops. It is not that a healthy individual with healthy functioning mind just develops this. This is actually an effect of these substances which produce a change. It is a pathology that is produced. And we have done the mechanisms of those pathologies in the previous lectures. So this is criterion 6. Criterion 7, important social, occupational, or recreational activities may be given up or reduced because of substance use. So not being with the family, not being at work, or not having the recreational activities, going out with family or friends or whatever. They're given up because of the use of the substance. So these are all social impairments. Then is the risky use of substance. There are 2 criterion in here. Criterion number 8, this may take the form of recurrent substance use in situations in which it is physically hazardous, using the substance in driving, for example, or operating a machinery. So that is the risky use, criterion 8. Criterion 9, the individual may continue substance use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. So that is also risky use. That the individual knows that there had been a physical or psychological problem or an exacerbation of the problem, and they still use it. So that is risky use. Pharmacological criterion. So there are two in this, 10 and 11. Criterion 10, tolerance. And we have done this in detail, how tolerance develops, how tolerance within hours to days to weeks to months develops. So I've done those mechanisms before. Tolerance is signaled by requiring a markedly increased dose of the substance to achieve the desired effect, or a markedly reduced effect when the usual dose is consumed. So either the person takes more dose of the substance to have the same effect as before with the lower doses, or they use the same dose, but the effect reduces. So now the tolerance is developing. Please remember, development of tolerance will happen in legitimate use of a drug as well. So, for example, if opioids are used for a patient for their need and the patient becomes tolerant, that is normal. Criterion 11, withdrawal. Withdrawal is a syndrome that occurs when blood or tissue concentrations of a substance decline in an individual who had maintained prolonged heavy use of the substance. That is withdrawal. And we did this discussion in full detail, that what are the mechanisms, how does body change during the use, that when the use is stopped, what are the effects, what are the physiological and pathological mechanisms that occur that cause withdrawal. So we've done that discussion before as well. So here, criterion 11, withdrawal. Withdrawal is a syndrome that occurs when blood or tissue concentrations of a substance decline in an individual who had maintained prolonged heavy use of the substance. Now, meaning the syndrome is occurring when the decline occurs in that substance, or the substance is reduced, withdrawn. This is also normal for a person who were taking a drug for the legitimate need for let's say, pain management or other effects, and they were taking a prescribed medicine and they were taking as was given, they could still develop withdrawal. So withdrawal alone or tolerance alone cannot just be said that this is disorder. So symptoms of tolerance and withdrawal occurring during appropriate use of prescribed medications given as part of medical treatment, for example, opioid, analgesic, sedative, stimulants, are specifically not counted when diagnosing a substance use disorder. This is very important. I think that this care is not taken as much by many of the providers, which is sad, but here it is, DSM-5 TR, the latest text, and it says here, symptoms of tolerance and withdrawal occurring during appropriate use of a prescribed medication given as part of medical treatment, for example, opioid, analgesic, sedative, stimulants, are specifically not counted when diagnosing a substance use disorder. The appearance of normal expected pharmacological tolerance, we discussed it, and withdrawal during the course of medical treatment has been known to lead to an erroneous diagnosis of addiction, even when these were the only symptoms present. So all the other symptoms, the impairment, social impairments, and others, they are not present. Tolerance and withdrawal is present. That is possible with appropriate prescribed dosage of a drug as well. And they are saying it over here, that the appearance of normal expected pharmacological tolerance and withdrawal during the course of medical treatment has been known to lead to an erroneous diagnosis of addiction, even when these were the only symptoms present. Individuals whose only symptoms are those that occur as a result of medical treatment, that is, tolerance and withdrawal as part of medical care when the medications are taken as prescribed, should not receive a diagnosis solely on the basis of these symptoms. However, prescription medications can be used inappropriately, and a substance use disorder can be correctly diagnosed when there are other symptoms of compulsive drug-seeking behavior. So just to refresh your memory, recent memory, here, impaired control, social impairment, risky use, and pharmacological criteria, tolerance and withdrawal. So tolerance and withdrawal alone cannot be used to create the diagnosis. Final two things. One is severity and then the specifiers. The severity of this diagnosis. So what you do is you say substance use disorder is mild or moderate or severe. And how do you scale that? Presence of 2 to 3 symptoms Again, tolerance and withdrawal alone is not going to be counted. Presence of 2 to 3 symptoms is mild substance use disorder. Presence of 4 to 5 is moderate substance use disorder, and presence of 6 or more is severe substance use disorder. And then the specifiers. Specifiers are, for example, when you are working with these individuals, the following course specifier in time, over time, specifiers and descriptive feature specifier are also available for substance use disorder. For example, or actually not example, these are the ones: in early remission, in sustained remission, on maintenance therapy, and in controlled environment. Now, if you said we talked about the severity and we had the definition of that, we looked at the criterions and we had definitions of those. What are the definitions of these? What does in early remission mean? Or in sustained remission means? And they do not have a generic definition. Rather, every type of use disorder, for example, alcohol use disorder, or for example, opioid use disorder, every disorder has their own definition of these features. So when you look at the booklet, so if I go back to the manual, and if you look through the manual, and as you see various disorders, substance medication induced sexual dysfunction, there is a criteria. Every one of these, and here are the ICD-10 codes, every one of these disorders would contain its own, if at all there is a definition for these specifiers, that would have its own definition for the specifiers. And that is the discussion. Next time, we will continue with opioid use disorder. So now we would dig deeper into various disorders. I especially want to talk about opioid use disorder. Then I want to talk about alcohol use disorder. We'll see if we should talk about smoking use disorder as well or not. And then we'll move towards the management of these. So I hope you liked this one. I would see you again in the next talk.